All right, today we will be looking at positioning and draping. I always fight with myself on what should I do first, positioning and draping or bed mobility. I think bed mobility is a little bit more fun. It's a little bit more active. I get to cover body mechanics, and that's something that we need. I mean, do I mention body? How often do I mention body mechanics? Is it every hour or a little bit more frequently than that? Probably a little bit more, right? So I like covering body mechanics first. I think that's why I generally go with that first. But this is kind of flip a coin. Which one should we do first? But anybody tired today? Yeah. All right, good. So we're gonna lay down with a bunch of pillows today. It's the toughest part about today's class is staying awake because you will be laying down with a million pillows all around you. But while we make light of it in class today, this stuff is positioning for our patients are crucial because we want to, number one, we talk about preventing skin breakdown, preventing pressure ulcers. Decubitus ulcers are the other name for it. Sometimes I usually use the term pressure ulcers. Sometimes I use decubitus ulcers. That is a preventable problem. And one of the other reasons a lot of skilled nursing facilities and hospitals are really on top of this. One, we don't want to add to our patients' problem list, right? We want to start taking away their problems. Two, some insurances have started not paying for the care to make those wounds better. No, this person came in without a wound. Now they have one. It's on you to fix it. We're not paying. So it's a big problem. Preventing contractures. What were those contractures again? We mentioned that a little bit. Stiffness is a good point. Yeah, stiffness is a good broad term for it. So it's just the joints, the muscle can no longer elongate to its normal arc of motion, its normal resting position. Why do you think that's a problem? Yeah, loss of strength easily. Loss of function, definitely. I've got a guy that I've been seeing for years. He had a TBI close to 20 years ago. He's comatose. I go in to see him every other week, and I just do range of motion to prevent contractures. Odds are, what do you think his prognosis is? Is he gonna just wake up over the weekend and say like, "Wow, I feel rested"? No, he's there, right? Why do I keep doing it though? Good, adequate blood flow. Good. What else? It's got no function and little hope for function. So I think for some people that will be right. So somebody could have a major car accident, medically induced coma for a little while, and then all of a sudden they do have a prognosis. One of the other things to think of is if we allow this guy to get contractures, if we allow his elbow just to be in this stuck bent position and we can't straighten it out, how's the hygiene going to be in that crevice? You can't take care of it, right? So now we will definitely be growing bacteria and funguses and create skin problems in that area. So that's one, just basic hygiene is one of them. If I allow more contractures, then I'm going to be, if we were to lay someone flat on their back in supine, but they had knee flexion contractures, meaning they can't straighten their legs out all the way, I just increase the amount of pressure on their heels because they can't straighten out their legs all the way, right? Their heels are in contact with more weight through it. And now that is at risk for a pressure ulcer because we couldn't position the patient appropriately because we have those contractures. You see how that tangled mess gets, right? So preventing contractures is really important, even for someone who has little prognosis. Someone who does have good prognosis, yes, we do not want to fight this down the road. Maintaining circulation and patient comfort if they have sensation, definitely. Yeah. So, our textbook and the verbiage we are trying to use is pressure injuries and not necessarily pressure wounds, because the first stage, does anybody know anything about pressure wounds, the stages of pressure wounds? I said it again. I immediately said we're going to try to use pressure injuries and not wounds, and the next opportunity I had, what's this first stage? Just redness, no broken skin, right? So it's a little bit of a verbiage problem when we call something a wound, but the skin's not broken. So the more inclusive term is pressure injuries. I'll say it again. I'm going to try hard to keep using pressure injuries. What time? Let's see. Somebody put their timer on and see how much time I last not making that mistake. So how do we get it? It's localized damage to the skin or underlying soft tissue or both, usually over bony prominences. The bony prominences are the at-risk places because that's where the area of pressure is going to build up. Just like when we palpate someone, we don't use the tips of our fingers because there's so much pressure there, it's uncomfortable, and we use the pads. That's the same reason why the bony prominences are going to be at risk. There's just so much more force in that area. Did you have something to? Yeah, absolutely. Yeah, when we're sitting right now, our ischial tuberosities are the things we're weight bearing on. Yeah, yep. Anybody have an armrest on their chair? Electron processes coming in contact, right? So other factors that contribute: age, body condition and composition, disease state, any other circulation issues or metabolic disorders. Can they move at all? All of these are additional risk factors. I always love this. The biggest risk factor of a pressure injury is history of a pressure injury, which is like, come on, man. Like, but whatever factors happen to create that first one, you still have most likely. So two primary factors. Number one, pressure on soft tissue that exceeds normal capillary pressure of local circulation. So do this just kind of on the back of your hand or forearm. Press into your skin and it should kind of blanch. It should turn white. Why does it turn white? What did we just do? We pushed all the blood flow out of there. If we held it there for a while, why is blood flow important, broadly speaking? Nutrition goes to tissue, waste travels away, right? So if we restrict blood flow, nutrition can't go to that tissue and waste don't pull away. Eventually we start getting cellular death and necrosis. So yeah, any pressure that exceeds capillary pressure, we're in trouble. The other one is shear forces applied to superficial skin. So everybody, if you could slide in your chair just a little bit more. No, other way. Yeah, look. Yeah. So that kind of reclined position, what's gravity doing to his body? Pushing him down, right? It hasn't changed yet. So gravity wants to push him off of his chair. What's stopping that? It's the friction of his tissue is not letting that happen. So, the forces are gravity's pushing him this way. The friction of his skin and other tissue is creating that way. And that mechanism, those combined forces, cut off all the blood supply. So that is a high risk. Thank you for showing us, Dallas. So that is a huge risk for our patients. And for my patients who are in their recliners all day long, that's a huge problem. So that's that shear forces. We talked about it a little bit too when we're doing our dependent patient mobility. We are using draw sheets to try to reduce friction, try to not slide that patient. We do try to alleviate the weight of the patient to the bed to move them along. But if our patient's in more of a home care setting, how many Do you think that's really possible for some of these situations? No, right? So really educating our caregivers about that shear force, huge problem. So risk factors from the textbook, again, I think this is the 6th edition page number. So, it's ballpark close to that, depending on the edition you have. So pressure on tissue over bony prominences, that's number 1. Shear and friction forces, that's the next thing. But nutrition and fluid intake, lacking sensation. Now, I think this is probably in the next slide and something we talked about. What's the turning schedule for somebody who's dependent? Every 2 hours to prevent skin breakdown. And if we're using a wheelchair, every 15 minutes, we should do some sort of pressure relieving activity. How come you guys don't get pressure injuries after the 2nd week of school? I mean, you guys are sitting in these chairs for all day long. How come you're not getting pressure injuries? So you don't have a lot of, you have good nutrition, you're younger, healthier, you have good blood flow, absolutely. So there's a lot of risk factors that you don't have. I have people who are young and healthy, otherwise get pressure injuries.
So, I will assume most of us have good posture, sitting here for a long time.
You guys think you have perfect posture all day long sitting here? No. There we go. We're moving around a little bit. Do you guys ever think like, oh, let me lean back a little bit. Let me sit up a little bit more. Let me turn. Do you ever think about that, or does that just happen? Why does that just happen? Yeah, I don't even know. You're uncomfortable is a good way to describe it. I'm not sure the body senses that. What the body's doing is it's sensing that lack of blood flow in the area of pressure. Ischial tuberosity is the easy one. And then you automatically shift to get on one side, shift to slide back, shift to get back, right? So you're doing it automatically. That's your body has sensation, tells your brain what to do. Your brain says, okay, let's move, and you alleviate that problem. If we don't have sensation, we can't do that. I'll tell you one story about a guy I had. He had a pressure wound on his right heel. Diabetic mess. It's just a train wreck of a person. The nurse saw him day 1. He had a thumbtack in his other foot, walking around on it. You guys, anybody here this morning have like a fold in their sock and they immediately go like, I can't do that, right? He is walking around with a tack in his foot. That's how bad some of these sensation is. Now, if any of us walked around with a tack in our foot, what would our foot look like tomorrow? Mangled mess, right? And then there's the risk of infection is sky high. So huge problem. That lacking sensation is a huge problem. Incontinence is another huge risk factor. Especially if we combine the lacking sensation too. So if our patient urinates themselves, doesn't realize it, doesn't have any control to not do it, and then they're lacking sensation, now they're sitting in a moist environment, that is going to cause more skin breakdown. You guys ever get out of the pool or something and your fingers are all wrinkled and stuff? You think though that skin, when it's in that condition, you think that's easy to tear or tough to tear? It's easy, right? That's what moist environment does to their skin, right? So if our patient's sitting in a recliner, has some shear forces, has some incontinence, has some lacking sensation, that person is going to get a pressure injury because of all those factors. Metabolic disorders, especially diabetes. A lot of the metabolic disorders, diabetes, it really destroys the microcapillary system. That's the big problem. That's why we lack sensation. That's why we lack blood flow. That's why healing is so limited. Same thing that tobacco products does too. And then reduced mobility and contracture. Again, reduced mobility because if the patient can't move, then they can't alleviate that pressure. If they have a contracture, it's going to create an area of high pressure somewhere else because we can't spread out those forces. So some interventions. First up, relief of pressure to bony prominences. Now we've got a couple different hospital bed types that we could use should we need to, right? So that's something we looked at last time. Do you guys remember the names of those? I only remember one off the top of my head, to be honest. The Roto Rest is the only one I remember because I just get a kick out of it. Yep, air fluidized, good. Anybody know remember the other one? Yep, yep. So we could change beds because those will reduce pressure, so that's good. One of the things we have to start thinking of, do we want to reduce pressure or completely relieve pressure? So if I'm sitting with my elbow on this and you think like, hey, that's a risk for pressure injuries. If we put a pillow here, now it's a softer surface versus a hard. I've reduced my risk to some degree, right? Or if I grabbed, let's see if I can create this. If I created like a donut and I put my elbow, now I've completely relieved the pressure of that olecranon, right? So there's some thought process. Do we want to reduce the pressure or do we want to completely relieve it? When do you think reducing is a good idea versus completely relieving? It's kind of getting ahead of ourselves, but let's. If there's a wound, or what to anybody get the time? If there's an injury, if there's a, hey, not bad, not bad. 11 minutes. So if there's a pressure injury, then we should relieve the pressure. If they're only at risk, then I'm sorry, that we should eliminate. If there's only at risk, then maybe just reducing the pressure. So that's part of our thought process. So we talked about this turning every 2 hours, change of position every 2 hours. We could also do modified positions every hour. We will work through those, what that means in a little bit. Obviously improving nutrition and fluid intake, mobility exercises, debriding necrotic tissue as necessary. What does that mean? Remove dead tissue. So the problem with dead tissue is that it blocks healing. So we would have to remove that. Now, as a physical therapist, I don't and won't, but I could use things called sharps, tweezers, scalpels to remove that dead tissue. I don't have the training to do that, but my license says I could. In Rhode Island, I could. Not every state I could do that, but in Rhode Island, I could. As a PTA, you have some other tools for you, so you can't use tweezers and sharps. But you can use things like water. So basically, you take water and you squirt it into a wound, and that amount of pressure of the water will remove some of that tissue. The other one you can do is called wet to dry dressings. So we put on a piece of gauze over a wound as it's wet, and then we let it dry. And then what do you think you do? Rip it off. That's exactly it. And all the dead tissue and some of the healthy tissue is going to stick to that as you get it off. Remember how we said it's so hard because our patients have to trust us, like us? What do you think about your patients if you're doing that? How's that relationship going? Tough. But we could do that. So that's the breeding of dead tissue. Wound cleaning. Being consistent with thorough perennial care, especially if the patient's incontinent. There are different moisture barriers. If you've ever changed a diaper and seen a diaper rash, there's a whole bunch of different ones that you could use just so that the water, it beads off of the skin instead of stays on the skin. Rinsing injury with sterile saline. developing wound dressings, schedules. Education is the number one thing we have to give our caregivers, patients, everyone involved. When I was working at the hospital, I had this woman who had a massive stroke, and she made little progress in the time we were with her and their family. This is many years ago now, so maybe my memory is a little fuzzy. It felt like I think she had 4 sons. It could have been 2, it could have been 20. I think it was 4, and each one was bigger than the last. They would make Gonzo look tiny. Like, this was when they said, "Oh, the sons are going to come in. They think they're going to take mom home," and it's like, wow, this is going to be a tough conversation. She can't. So when we said, "All right, we want the best for mom too. We think rehab nursing home is probably the next best place for her. You want to take her home." The big thing you got to figure out with the mom, she can't move herself, so she needs to be turned every 2 hours. And this family, I mean, I really love them because they immediately went into scheduling. All right, I got Mondays and Wednesdays. I got lunch off. My work, I'll swing by. I'll set. So they started figuring that out. And then one of the other staff said, "Okay, what about overnight?" And they said, "Overnight too?" Well, that's a lot different, right? So even they, 6'6", 300 pounds of each one. There's plenty of them. They could physically do it. That was another thing. If yeah, it's every 2 hours round the clock. So really tough. So that education is really important. Preventing contracture is really important too. So we have some different stages. I do have some pictures for us that we will look at. If you get squeamish, you can feel free to look away. If you need to turn around, if you need to take a step out, that's okay. My buddy Pat McCormick, guy graduated. I'll tell you a handful of Pat McCormick stories throughout our time together. Amazing guy, brilliant guy. If we started talking about blood, he'd have to go lay down in the back of the classroom. He could not. Did you guys do the bloodborne pathogen quiz yet? You got to do that if you haven't done that yet. What did that take? How much time did it take? Little 20 minutes maybe. I forget what it would take him hours because he would have to stop and lay down every like 3 minutes, just like talking about blood. So if you're one of those people, I get it. But let's look at some pictures to get a better idea of what we're talking about. So if you wanted to look at the real anatomical terms for it, you could look at the stages of wound for how deep, what layers of the skin it penetrates. And I think that's really good tool for us. I really like this picture to show us stage 1 involving only the superficial layers. Stage 2, it's really shallow, but the skin is now broken. Stage 3, it's now deeper. And stage 4 is all the way through the underlying tissue. So I love this picture and how it shows us that. But what I can tell you is the stage 1s, the skin is intact, but it's non-blanchable. So you guys know when you pressed on the skin, it turned white and then it turned back to its, it turned pale and then its original color. Non-blanchable skin means it doesn't turn pale. It stays that almost pinkish color. I think the best way to describe it is it looks like a sunburn. That's probably the best way to describe it. If you can see that picture, that one's pretty good. It's not going to come up here, but that little area there. What anatomy are we looking at? A little tough to figure out, but looks like the calcaneus. Yeah, heel. All right. So we know that, first of all, is that a bony prominence? Yep. And we know that, I'll give you a little preview. Different positions are going to give us different at-risk areas. So right now in this sitting position that you guys are in, what's your highest at-risk area? We gave this Ischial tuberosis is the highest at-risk area. What position do you think this patient was in? I think supine probably makes the most sense. Potentially seated on a footrest, potentially. Yep, good. So that's a stage 1. Skin's intact, non-blanchable, looks like a sunburn. Stage 2 looks as simple as like a broken blister. Like it's not bad, but the skin is broken now. The skin is no longer intact. Involves the epidermis and some of the dermis. Right there we get that little bit of broken skin. What anatomy are we looking at here? Sacrum, good. Patient position. They're inside lying now, but if they're inside lying, do you think the sacrum's at risk? If we are inside lying, though, where do you think, like, automatically, where's the highest risk area? Greater trach. Great job. Great job. All right. But where do you think this patient was in order to get a stage 2? Potentially supine. I'm thinking because it is a sacrum, some sort of reclined, seated reclined position. That's what my gut is telling me. But yeah, it could be supine. Yep. So that's a stage 2. Again, shallow, broken skin, though. Stage 3, deep crater. So we're in the deep category. Involves epidermis, dermis, and subcutaneous tissue. But the deeper structures of bone, muscle, tendon, ligaments, they are not exposed. So here's a picture of that. Just a little bit. This one's not a bad stage 3, but just gut feeling looking at it, is that a little bit worse than a broken blister? Yeah, like there's definitely worse stages 3s, but that's a stage 3. You all right? You're gonna make it. Wait till the next one. Cartoon, that drawing was way better than this, wasn't it? All right, stage 4. One thing I will tell you, sometimes we see just maybe a little bit here, just might be the lighting. There could be something called slough present. Slough is like whitish tissue, and that's okay. That's good tissue to have. I think for an untrained person, we don't know if that's infected or slough. I still get confused sometimes. But when you see it a lot, you'll be able to know the difference right away. But it's that whitish kind of tissue. All right, stage 4, deep crater, potentially have tunneling. So tunneling is, this has kind of a border to it. Tunneling is, it goes deeper there. The skin remains intact on the superficial area here. But if we were to take a Q-tip, the Q-tip would just start traveling on us. So that's what a tunnel is. Stage 4, the big difference is that it exposed deeper structures. Some of this material is slough, some of it's not, but the tunneling is present. We have some necrotic tissue here. Some of the muscle over here exposed. That's where the stage 4 is. So if you can see any of those deeper structures, that's a 4. And then the last thing we have is unstageable. So unstageable is because there's something in the way for us knowing exactly how deep it is. That's that dead tissue. Anybody know what that black necrotic tissue is called? Eschar, yeah, Eschar. So that's that. That's black, leathery, necrotic tissue. We don't know the extent of this injury because this stuff is in the way from letting us know. That stuff needs to be removed before we can actually, well, it's not going to heal with that stuff. That's blocking healing. So somebody other than me and you will have to take that off. So that's that scar right there. All right, so I think on a written exam, if the verbiage can give you a clue as to what the answer is, right? So if the options on the multiple choice are stage 1, 2, 3, and 4, there's a couple of key words that you should be able to recognize. Stage 1, non-blanchable. If it says non-blanchable, that's like your neon sign saying stage 1, stage 1. Stage 2, broken skin, shallow. I think those are kind of the key words for that. I think stage 3, deep, but not deeper structures. Some sort of verbiage along those lines. And stage 4 is any of the deeper structures exposed. Those are your highlight words. Now, sometimes I have trouble when Tony, do we have a model of the wounds? Do we have? Yeah. That's all right. So sometimes exams will have pictures, either exam for my class, licensure exam, some of your exams going forward. So sometimes it's pictures, and sometimes we have models. And I got to tell you, even sometimes when I look at patients' wounds, I look at it and I go, well, I don't know what that is. It's tough for me to stage. So for me, when I see a picture of a wound, a model of a wound, or one on the patient, I go through a thought process. I go through kind of a checklist first. My first question is it superficial or deep? If it's superficial, what are my choices now? It's either a 1 or a 2. What's the difference between a 1 and a 2? If the skin's intact. All right, if the skin's intact, it's got to be a. And if it's not intact, it's got to be a. So if you look at a picture and you say, nah, not that deep, but the skin's not intact, great. You know the answer. If you look at a picture of a wound and you say, oh, that looks deep. Not like emotionally deep, like a poem, really, like structurally. It looks deep. Okay, what are my choices? 3 or a 4. And then what's the difference between a 3 and a 4? Tunneling or deeper structures are the best answer. Deeper structures are the best answer. Because, could a stage 3 have some tunneling as long as it doesn't expose the deeper structures? There's some wiggle room there. The deeper structures are the concrete yes or no answer. So anybody here, so when we start talking about wounds, I usually have one person per group that someone likes wounds. Somebody would like to be part of wound care and healing wounds and looking at that stuff. Does anybody here immediately think like, oh, that's definitely me? No, everybody's like, yeah, me neither. Oh, yeah. Oh, yeah, right. Yeah, so she does it all the time. I know some people, yeah, some people. Good. I'm glad someone in the world likes to do it. Yeah, I don't want to be it, but yeah. So even though you might not be directly caring for those wounds, it is still your responsibility to keep track of those wounds. And especially in the home health setting, nurse might not be coming for another 4 or 5 days. And especially in the rural parts of the country, I have a friend who does home health in rural Louisiana. He'll tell you some stories. It might be a week before the nurse comes back because the territory is 5-hour drive, like the 5-hour drive radius. So he has to do it, right? And even though he might not, for me in Rhode Island, I've got plenty of nurses. I've got such a great staff that works for me. If I have a problem, I can call someone and someone will be there this afternoon or tomorrow. First thing tomorrow. My buddy in Louisiana doesn't have that. It's a 5-hour drive. If he needs help, it's a 5-hour drive. Not going to happen, right? So we still have some responsibility. And even if the nurse is in the next room next door in the hospital, we still bear some responsibility. So we should be able to identify the stage. We should be able to measure a wound. If there is a wound, we should be able to measure at least its width at the widest point and its length at the longest point. We can measure depth either by staging, or we do have sterile with cotton tips, sterile measurings, kind of measuring Q-tips, it looks like. You can put it right in the wound. Describe the wound edges, looking for tunneling, looking at the exudate, that's the fluid coming out of the wound, looking at the color, the amount, and the viscosity. I think for the most part, if the fluid coming out of a wound is green and thick and smelled bad, I think we would all say like, all right, well, that's an infection. Sometimes it's a little bit more subtle. Oh, perfect. Yeah, I've even seen some that have it's printed right on the yeah. That guy with the heel wound and walking around with a tack on the other side, at one point he had a new infection of his heel wound. He actually, to give away the ending of the story, he had to have his calcaneus amputated because it never healed. It was a 2-year ordeal and it never healed. So that was pretty interesting. I've never heard just a calcaneus. Grab this calcaneus right off. Yeah, that was something. But I saw him at 1 o'clock. The nurse changed his dressing at 10 o'clock. By the time I saw him, the dressing was dripping wet. Clear fluid, but completely saturated. And I thought he spilled like his water on it. I thought it was like sitting like this and like something crazy happened, but it all came from the wound. And I had to call the nurse and I said, this thing is dripping. You could see it dripping out like that. So that's the amount is unusual. Yeah. Yeah, I think we had to just build up the heel in his shoe. He didn't have to have a specialized prosthetic. It was pretty interesting. After 2 years of trying, it was something. This guy also, at one point, the doc said, okay, I'm going to put you in a cast and you have to be non-weight bearing. And after a week, the bottom of the cast is all worn. The edges of it are splitting because he's walking on it. Like, are you putting weight on it? No. All right. Anyway, observing necrotic tissue. And then we can look at the characteristics of the wound. Do we have granulation tissue, epithelialization tissue? Is the wound getting smaller? We'll look at some of that down the road. I want to focus a little bit more on positioning and draping. So one thing for us, we should always have a plan, right? We're reviewing the chart. We should have a plan before we walk in with our patient. Once we walk in with our patient, we observe them again, we're thinking we're more in the hospital setting right now. So if they're in supine, we're going to be performing our treatment. What position should we not leave them in when we're done? supine because they were just in supine, right? So we probably opt to choose something else. Now, if they're really hard to move around, then maybe we perform our whatever things, exercise and things we need to do in supine. Then we move the patient, do whatever things we need in side lying. Like there can be some planning and using of what the patient position is after that. We have to know how to prevent contractures and skin breakdown. We'll get into that a little bit more. Patient factor. I love this line. Patient factor is only one factor to consider. Our patients want to be in supine. That is a comfortable position. Or how many people always sleep like right side lying when they go to sleep and they wake up and they're right side lying, right? So we have our own positions of comfort, but if that's contributing to the skin breakdown and contractures, we can't be there, man. I know you like it. We'll try to do that more often, but we can't be there right now. It should occur every 2 hours, like we said over and over again. Modified position or complete change every hour if we need to. Other interventions, compression stockings, metacompression to prevent DVTs, some active range of motion, potentially to prevent DVTs. And then we can always use additional devices, pillows, footboards, trochanter rolls, hand rolls. So hand rolls would just be to prevent hand contraction, just adding in a little something there. Wedges, bolsters, towels. You got an imagination, you can use whatever it is. We'll look at some of that in a little bit. All right. So before we get into this, what I want you to do, let's go. You guys have supine. You guys have side lying. You guys have prone. And you guys have sitting. I want you guys to come up with all of the at-risk areas for skin breakdown when you're in that position. Once you figured that out, I want you to come up with all of the at-risk areas for contractures. Okay? All right, let's spend some time, talk with your classmates, figure that out. What did you guys have? What position? Supine. So you guys had supine. Let's start with bony prominences. What bony prominence is at most risk? Well, what bony prominences are at risk? I mean, we wouldn't say sternum because, you know, so all of them that are at risk. All right. You guys are doing exactly what I thought you'd do. So in each position, there's like the highest risk. Sitting ischial tube, like that's a big problem. But if we only care about the ischial tube when we're sitting, we're missing all of the other at-risk bony prominences. So what we would always like to do is have a systematic approach to any screening or thought process we have, not just throwing it against the wall. So you can start from the head and work your way down, or you can drake it and work from the bottom and get all the way up. Okay. So, come up with a better way to describe. Are you not a Drake fan? Do you not get that joke? Is that no? I'm more of a Degrassi fan than a Drake fan, but all right. So come up with a better way to describe. So if patients in supine, either start at the head and tell me all the at-risk problems going down, or from the bottom and up. It doesn't matter. But just saying like, oh, well, sacrum, heels, elbows, like you're just all over the map and you're going to miss something. So what's the next thing? What's the starting point? Patients in supine. Start at the bottom. All right. Good. So what's the first? Calcaneus, posterior calcaneus. Good. Next. Probably, yeah. Sacrum area is probably the next most common. Scapulas, nice choice. Yep. Elbows, potentially. Yep. Potentially, yep. Wrist, occiput, good. For some people, the spinous processes are also can be. I had one woman, she was on a good day, she broke 80 pounds. And she was also so forward flexing kyphotic that those spinous processes, like you could count them from across the room. And if she's in supine, that is a huge at-risk piece. So for some people, spinous processes, good. PSIS, yeah, I think that's true. I think that's perfect. Yeah. Yep. I think if we wanted to be particular, we would say sacrum and PSIS separately. I think they're right next door to one another. If you're looking at one, you're looking at the other. So I think testing wise, it's probably good to think of that. Realistically, it's the same thing. You're looking at the same thing when you're looking at your patient. So good. All right. Risk for contractures. Okay. Well, so I think if we're, can someone lay in supine for me? Just so we can see. So I think for some, if we're talking about risk of contractures, I think the shoes are blocking a little bit. Does everybody sleep in neutral feet when we're in supine? I think most people we were like this, right? So now we're at risk for a plantar flexion contracture here. Now if you're like me, you got a good angle at it. Do you see how his toes are just slightly pointed out? So, I mean, if you're like me, it's way out like that. So now we're at risk for being stuck in external rotation. And, he's laying nice and straight here, but anybody, maybe if we sleep like that, right? So now we're at risk for elbow flexion contractures. Maybe their fingers and wrists as well. Yeah.
Depending on the pillow.
Yep. Good. Anything else? Especially if we're in this position.
Oh, yes.
Potentially, yeah, could be. Yep. Good.
Oh.
So especially in this position, we're stuck in internal rotation and potentially scapular protraction, I think is the best way to describe that. So yeah, so we've got some at-risk parts here. Good. What did you guys have? You had side lying. Okay. So first, let's do risk of skin breakdown. Anybody want to get in position just so we see?
So I guess we'll start in the bottom here. Depending on how he has his feet, I guess definitely lateral malleolus. I
Yep.
would say. Maybe the medial as well.
Perfect. Yeah, so the lateral malleolus of the bottom leg and both medial malleoli. Yeah, good. If we wanted to, maybe different aspects of the foot as well. Does that metatarsals, we'd have to look at it. So potentially there. So good, keep going.
Well,
good. Both medials and the bottom leg lateral. Good. Great. Great.
The shoulder, like probably.
Head of the humerus, acromion, yeah, yep. It's again one of those like textbook. We'll have to really look at the wording. Patient wise, if you're looking at the acromion, you're also looking at the lateral of humerus too. So,
And
yep,
then the elbow as well.
yeah,
How he has a position.
yeah,
Approach up like this, or straight out, maybe not as much.
yeah, yep, good. Anything else? Anybody see another one? I think it's two, yeah. So yeah, the ear, mastoid process, jaw, zygomatic arch, all of these lateral structures on the lateral head and face, definitely. Ribs, lateral ribs on the bottom side definitely could be as well. Yep, good. Risk of contractures.
Flexion.
Good.
Possibly.
Good. What do you guys think of what he just did? Does he have a systematic approach to it, right? So no, let's have a nice systematic approach. So probably foot plantar flexion, ankle plantar flexion, I should say, knee flexion,
Definitely.
hip flexion. Could be, yep. And adduction too, yep.
Elbow flexion.
Yep. Possibly both sides, yep. Depends on the pillow positioning. You know, could be lateral flexion. Yep. Anybody ever sleep one night on a pillow that's a little bit too big? Wake up like this the next day? Yeah, yeah. And then same thing for the shoulders, internal rotation, scapular protraction as well. Good. What did you guys have? Whoa. Prone. Who wants to get in prone and start walking through with me? Good. Let's go risk of skin breakdown first.
Starting from the top, depending on how you're lying, could be the cheek,
Yep.
on your face.
Yep. All of those lateral face and neck structures. So jaw, zygomatic arch, mastoid process, ear, all of that. Yep.
And then the downward, the clavicle area.
Absolutely.
Chest, especially for women.
No bony prominences there, so good thought. I'm a little bit more concerned with the sternum. That would be something a little bit more at risk, but good thought.
And then
Be more specific than pelvis. AS, yeah, ASIS, yeah, ASIS, good.
and then ankle.
If we were to be more specific than just knees, patellas, good. Yeah. Oh, yeah, sure. Yeah, could be malleoli, depending if we have something wacky. Okay, good. And then risk of contractures. Yep. Good. Anything in between the feet and the neck? Potentially being stuck in a little bit of extension.
And then depending on
Yeah, here we're stuck in internal rotation. Yeah. Yep. Good. Any other risk of bony prominences or contractures? I think you guys did a good job. And what was your last position there? Seated. Okay. Who wants to be my seated model? You're gonna be the model. All right, good. Yep.
So someone has like a posture and there's the rest on, then the bad posture could be around his shoulder.
Good.
Just tight on the pecs.
Yep.
And then also, the scapula, just like it was mentioned
Yep.
earlier, the protraction, it will constantly be in that.
Yep.
Stated. Then we also mentioned the pressure, the risk of pressure, obviously the.
Hold on. Are you done with risk of contractures yet?
No.
Stay this. Yeah. Just do one. Just do risk of contractures head to toe, and then we'll move on to skin breakdown. Okay, so shoulders, risk of contraction, turn rotation, scapula protraction. Next up, you have what?
Oh, yeah, the hips.
So sucking hip flexion. Good. Next up,
And then we put a hamstring.
hamstrings or knee flexion contracture. Yeah. Yep. Yep.
I would say that was main. Now, if there's like a footrest, you could have a contractor there.
Great thought.
With dorsiflexion or plantar flexion.
Great thought. If we have a full rest, we're probably falling into plantar flexion. But yeah, good thought. All right, skin breakdown.
So the skin breakdown, so he's gonna recline position, so that could affect the scapula, and it cause
Yep.
rubbing there. And also the sacrum could be affected, depending on the incline, depending on where the crease is. And,
Okay. Do we skip anything in between?
elbow.
We miss anything?
Oh, there's a,
So you said scapula. All right. So if there's a headrest, occiput, scapula, specifically the spine of the scapula, and then you said sacrum. Okay. Anything in between scaps and sacrum?
I mentioned the electrical.
What is it? Potentially spinous process on the depending on the anatomy of the patient. Yep. All right. Good. Olecranons, definitely.
Greater trochanter, because the seat's too small, they're like.
Okay, so if the walls of the seat are really tight, boy, that's a great thought. Yeah, tight fitting recliner, tight fitting wheelchair. Yes, now that is at risk.
The space, so edging of the chair is right up in there.
Yeah, not a bony prominence. So a little bit like the thought of with women in the prone. So it's something that could potentially be at risk, but not necessarily bony prominence. Yep, good thought. Good thought.
Oh, the calcaneus.
Yep. Yeah, I think the calcaneus would be the next big one. Good. All right. I think he did a great job with that. Did it come easy to you? For the most part, it was easy to look at the position and look at what the at-risk points are for both skin breakdown and contractures. So I think the only thing I would say is really for anything that we do, you should have a systematic approach to what we're doing and not just let's try this, right? What would you think if in your treatments you said like, all right, well, let's do this. Let's do this bed mobility. Oh, you know what? Let me go do vitals first. Let's do this strengthening exercise. Oh, you know what? Let's go back and work on bed mobility. Like, no, we want to have a sound thought process and procedure, not only for each skill that we do, but also each screening that we do, each test that we do, and also our treatments overall. All right. Why don't we take a quick break and then we'll come in and play with some pillows and get comfortable, okay? Let's take 10 minutes. Okay, so what we're going to do next is we're going to figure out how do we position all pillows so that our patient we are minimizing risk of skin breakdown is the number one concern. The number two thing is we've talked about each position has its risk of contractures. So what's important us to figure out is if I think my patient's at risk of knee flexion contractures, which positions would amplify that risk? Side lying is probably the most, and as well as seated. Which one would probably help us eliminate that, would minimize that? Probably supine. maybe prone, depending on how we have to adjust pillows. So, if my patient's at risk for knee flexion contractures and they're seated, I don't want to say, hey, we need to change positions. Let's go side lying. Because I didn't eliminate that risk of knee flexion contractures, right? So this is one of those, what I think it was you, Danica, when the other day when we said, gosh, we haven't even gotten out of bed yet. Like, there's so much information, right? Here's another thing. We're in bed and there's so much we've got to think about now. So it's okay if it's a little overwhelming. We'll work through it. So first up, we will go. Do me a favor, throw pillowcase on each one of those. First up, we're gonna go supine. All right, so first up, come on, supine for me. Now, obviously, if we had a bed of some kind, these are just our plinths, so we don't have as much space as we would if we were in the other room. So first up, our pillow is in underneath the head, but what we'd like to do is also sit up just a hair for me. I'd like to bias it right over the go ahead, that's it. Covering the spine of the scapulus too. If I do just the head, and especially if it's a big, this is a pretty flat pillow, but if it was a big fluffy pillow and I did just the head, what do you think of the neck position? Really stuck in flexion, might be comfortable for now, but eventually it won't be, at risk for some contractures. Did I do anything to prevent skin breakdown at the spine of the scapula if I have a big fluffy pillow only at the head? So getting it right at the spine of the scapulas as well. Again, this is a pretty flat pillow. If this is my patient, I'd probably swap for a bigger, thicker one, but we'll be all right for now. Then under each arm, good. Now I could ask for his arms to be straighter. I could let them bend. I have to, right? That's one of those, it depends. We got to figure out with the patient what's the best for us. Next up, I want to go lengthwise under calf so Achilles has no pressure. So lengthwise under calf. I can pull this up a little bit so it's calcaneus, and if I needed to pull it up even more, I could. Just so there's nothing at that Achilles. All right. Next, I can do a hand roll if needed, right? If I wanted to prevent contractures of the hand, I would put either one hand or both hands. Give you both hands, why not? And then a trochanter roll. So with the trochanter roll, either another pillow, big towels. If he is rolling out, if his foot really is rolling out that way, I would have to block that somehow. Whether I did that, I mean, we call it trochanter roll because we're trying to block the hip. Sometimes that's tough to do and we need to block it down here. Once I figure out all of that, before I walk away, my next step is just to take a big, broad look. Does this look okay? Because even though I checked all of the boxes, there might be something else either unique for this patient. Maybe they're shifted one side or another, like what Tay had said earlier. If we're in the hospital bed with the bed rails up, maybe he's just in contact with the bed rail on this side. And I that's not on the checklist, but it is something you got to figure out, right? So before you leave, before you do anything, is this okay? And see if you want to fix anything. Okay. Any questions on that? I'll also show you quarter turn from supine. So this one, all it is, this is those half position changes. Every 2 hours, we'd like to move out of this. I can also every hour move him just a little bit differently in this position here. So it's not quite side lie, it's not quite supine. What we're gonna do is we're gonna wedge a pillow in his back. Again, depending on the size of the pillow, depending on the size of the patient, I don't love that. I'm gonna do it like this. Good. Right there, good. Come on back. I could do this a little bit better, but you see how we're just a little bit off of that supine position. I would like another pillow just to be underneath of this arm as well, right? So pillow under head, upmost arm. Oh, and then I need another one. This one would then come kind of like that. Again, depending on if he was a little bit more this way, then I would have to just keep adjusting all of this. Okay, so that's my supine and then quarter turn from supine. Okay, any questions on those two? All right, so your procedure is go through the checklist on exactly where these pillows should be. And then before you do anything else, take a step back. Does it all look okay, or is there something else we need to fix? All right, so let's work on those two positions first. We'll have to share some pillows every now and again, okay? All right, I stole all of yours. That was 3 there. I stole one of yours, Abby. I stole your hand rolls. I think these are yours, I think. All right, prone and quarter turn from prone. Would you mind again? So first up, pillow underneath the head. And I think this pillow should be flat. We don't want a really bulky pillow pushing us into cervical extension. I'm going to have to put this underneath your hips too. So underneath that diaphragm, ASIS area is where I'm trying to alleviate that pressure. Again, how far you have to just one of those look and see kind of things. Small pillow under towel under legs to keep toes from touching surface. So now we're like this. The bigger this pillow, the more at risk for knee flexion contracture. So we have to balance that as best as our abilities can. Now, one thing is this prone position, most people don't tolerate prone for very long. This might be the kind of thing where you'd say, listen, we've just got to be in prone for a little bit, as much as we can tolerate. We'll be back in 20 minutes. You know, so be prepared for the patient not to tolerate this, especially if there's respiratory problems whatsoever. We might not be able to be in this position at all. So something to consider. Quarter turn. Now we're going to, thank you. Yeah. Okay. All right. The answer is always, it depends, right? So there's a technique called postural drainage where we have all these different lobes of the lungs. We have anterior, posterior, and lateral too. So with a stethoscope, if we listen to each lobe of the lung, anterior, posterior, and we can figure out where the fluid is pocketing, we can put them in a position to use gravity to drain the lungs. So if it's upper lobes, we kind of want to be seated upright. That way gravity will help us drain it out and then back out. If it's lower lungs, we'd like to be more kind of legs elevated. If it's posterior aspects of the lungs, if we have them prone, gravity is going to help drain that. So that's what it sounds like the nursing is telling you. Where I'm concerned with respiratory is we need expansion in order to breathe. Where do we get that expansion from? chest and diaphragm. Can we expand really with diaphragm in this position? Not really. And then how about chest? It's more difficult, especially if there's a lot of weight to the trunk of the patient. So those are the concerns with respiratory I was talking about. It sounds like when you say, well, how come they did that? It sounds like more it's postural drainage. That's what my gut is telling me. All right, quarter turn. So again, we're going to go back. Good. Now we're just going to kind of wedge him with a pillow anteriorly. Looks okay. Pillow under head, pillow under utmost arm. We'd like to have another one. Thank you. Perfect. Kind of there if we need to. Both lower extremities flexed. Upper leg more flexed than others. So kind of this type of a position with more pillows. Okay. So again, look, what's that? That's how, yeah, looks great. Just more pillows we need now, right? So again, so your job right now is to go through the checklist. Do I have all of the appropriate positioning? Before you're done, take a step back and say, would I change anything? I think walking around, I saw some really good step backs and checking, right? So we saw Gonzo when he was in supine, one pillow behind his calves wasn't enough. We needed two separate pillows to do it. I liked how you guys didn't like where I think you were in supine and the calcaneus was touching the table, and you wanted to completely eliminate that, and you're trying to figure out how do we do that. What are some of the other things that you guys troubleshot along the way? I know the exactly positioning of bolsters and what bolsters we use to get you in quarter turn was big last time. Any others? Okay. All right. Yeah. Yeah. And then, I mean, like I've been saying here, like this pillow is too flat. Let me find a different one. There's always something that you're going to have to troubleshoot, and it will never be exactly the same each time. But your job is to go through the checklist. And then is there anything else I need to tweak? Okay. Let's see. I talked with you guys a little bit. You guys were in quarter turn from supine, and you were concerned about one thing. What was that one thing you were concerned with? The lateral ankle on the what is almost, it's tough to say, but almost the bottom leg is a good way to put it. And what we said is, you know, our job, because we're rotating positions every 1 to 2 hours, we might not be able to eliminate all risk, but because we're changing positions so frequently, that's how we minimize that risk. What's the position we would, so if we're in kind of left quarter turn, so that would mean my left leg is the foot that they're concerned with, what's the one position you'd stay away from next? Left sideline, because that spot on the foot and ankle has now been in contact with the bed for 4 hours. Even though we change position every 2, that spot has had prolonged pressure for 4 hours now. So I think the next position should probably be right side lying, or maybe supine, or maybe, you know, actually if we're quarter turn for supine's probably not the best thing either, but you know, maybe prone. So that's where, gosh, we're in bed and this is so hard, right? We've got to really think about these things. So not only skin breakdown, but also risk of contractures. So let's practice again, checklist, and then troubleshoot prone and quarter turn from prone. And so what were you so concerned with? So you wanted to get the pressure off of the toes in the prone position, but then you're increasing the risk of what? So the more aggressive you worry about the toes, the more you put at risk for knee flexion contracture. Boy, that's tough. And we don't know the exact answer when we've got our patient in front of us. I think what we had talked about was if my patient's diabetic patient plus foot/toe wounds equals amputation at some point. The risk, the healing of a diabetic person and the toes is really minimal, and if we give them a wound, then it can. So, if my patient is diabetic, I'll stretch out his hamstrings. I'll figure out the hamstring contracture, but it is so important to not give a wound to the toes. I think that was a great thought process. In the prone position, patient's tolerance, high or low? Low. So we might be changing out of the prone position in 20 minutes anyway. For a patient that's not a diabetic, not at risk for skin breakdown otherwise, I might be okay with a little bit of pressure on the toes because I know I'm going to come back in 20 minutes. We're not going to be here long enough anyway. So that's something to consider. I like the prone position because I can modify the height of the pillow and I can provide a little bit more of a stretch to the hips. That's what I really like the prone position for, is to try to get a little bit more hip extension. I'll be back in 20 minutes. That's all part of we call it clinical reasoning. Yes, the textbook says do all this stuff, but the textbook doesn't have your patient in mind. Figure it out. So that's all part of the quarter turn's great, right? All right, side lying next, if you don't mind. I think sideline comes most intuitively. So side lying, pillow underneath the knees. If I need to, I can have another one just above the lateral malleolus, just to make sure that, the pillow in between the knees protects the medial epicondyles. If the pillow is long enough and the lateral malleolus is not at risk, great, I'm done. I think on Gonzo's longer legs, we'll need a secondary either towel or pillow to do that. Okay. Pillow underneath the uppermost arm. Pillow under head, not shoulder. And then if I needed to, I could have some sort of wedge to keep him in this position. And when we use the hospital beds, we can use those bed rails and then we can fill in that gap too. So the equipment that we have at our hand, I know we're just getting some good reps now, but when we use the real stuff, we get to use the equipment that's available to us a little bit better. All right. Any questions on side lying? Let's get some quick reps on side lying. I'll finish up our lecture. We'll take a little break and we'll go through a whole big exercise after that, okay? All right, quick reps. All right, so some other considerations for positioning, and this is more of a recap, right? Keep in mind bony prominences at high risk for pressure injuries, minimize shear and friction forces, especially when moving our patients. Additional caution with patients who have decreased sensations, can't move their positions themselves, confused, heavily medicated, minimal soft tissue over bony prominences. That's that woman who barely weighs 80 pounds in the spinous processes. That's the additional concern that we have. Unable to communicate discomfort can be a big problem. Flaccid or weak extremities should not be placed in gravity dependent positions. And then we haven't really done most of this, but the most distal part of the extremity should be placed higher than the heart. It's not something I'm all that concerned with unless the patient really has circulation problems. Then I have to start being really focused on that. So let's just add one more layer of complexity, right? So, hey, what'd you guys learn at school today? Spent all day laying in bed. There's so much that we've got to figure out here, right? So patients who use wheelchairs for locomotion, Obviously, the ischial tuberosities are at risk of pressure injuries, scapula, spinous processes, olecranons, medial epicondyle humerus potentially. Back of the knees, not a bony prominence, but depending on the fitting of the wheelchair, we'll look at wheelchairs in I don't know, week 8 or 10 or something like that. Looking at the heels and the feet, especially if there's little loops to keep we call them heel loops to keep the feet in place. So that's all part of it. Reposition every 15-ish minutes. And then the selection of cushion, we'll get into that down the road a little bit too, but it's something really important to understand. I've got patients that use wheelchairs for locomotions, and sometimes it's brand new for the patient, sometimes it's been for a while. I've had patients, family members buy new wheelchair cushions for Christmas gifts because they can be really expensive. It's great, but there's a whole bunch of decision making that goes into which cushion to use and why. If a patient's incontinent, huge risk of skin breakdown. And if the cushion is foam, now that's absorbing moisture and creating an even worse environment to sit on than if it was made out of other materials. So something to educate our patient and their loved ones on. Obviously, the risk of contractures, we've gone over a lot: hip and knee flexors, hip abductors and internal rotators, shoulder adductors, extensors, and IRs. Didn't have a great place to put this, but I wanted to put it here. Restraints are, we have to be careful when we use these terminologies because we're not allowed to restrain our patients. Now, but I can use a seatbelt on my patient while they're using their wheelchair for safety. So there's a fine line there. So straps, seatbelts, things like that are okay to use for transporting a patient from one room down the hall. But what's not allowed is strapping a patient down because we don't want them getting out of bed. That's not allowed. There are some exceptions to that, violent patients, and there's always an exception to that rule. But we have to have specific orders for that. And those orders, in most laws, those orders only last for 4 hours. You have to keep putting those orders in every 4 hours. So 2 hours for adolescents, 1 hour for under 9 years old. So it's not, we have to be really careful on how we use these. And it's only for safety for transportation, really. Yeah. Yep. Yeah, because it's considered a restraint. Yeah. All right. So some considerations. Now with amputations, for all amputations, so we're going to be heavily involved in patient care after an amputation. The broadly speaking, amputation's first step is help the surgical wound heal. 2, there's a lot of swelling in the residual limb initially after amputation. We have to shrink that swelling, because if we had a lot of swelling and then we try to fit for a prosthetic, what's going to happen in another month? Swelling goes away, the prosthetic doesn't fit anymore, right? So our first stage is to shrink that swelling as much as possible. But we have to maintain range of motion for it. We'll look at some examples why that's so crucial in a minute. So transfemoral amputation, what's that mean? Through the femur, so also known as above the knee, aka above knee amputation. Great risk for hip flexion contracture. Now, if we developed a hip flexion contracture, we got all the swelling down, but the leg doesn't go to neutral, is that person's prosthetic going to work? No. So we have to, we talked about earlier when the diabetic patient risk for wounds over the toes, like it's a huge problem. Guess what? Risk for contracture after amputation is the number one thing we have to stop. Like, we'll deal with wounds, we'll deal with discomfort, we'll deal anything else. Just do not give this person a contracture, because now they can't start working with their prosthetic when they can. So it is the number one thing we have to do is prevent that hip flexion contracture. So what positions do you think, without even reading this, what positions would we want to avoid and what positions would we tell our patient to use? Avoid side lying. Okay. Seated, I think, is the big thing that we have to educate, because after amputation, it's hard not to sit. Yeah. Yeah. What do you think we'd like to promote as much as possible? Probably prone. Prone is probably the best one for our patients. So this says residual limb should not be elevated on pillow for more than a few minutes each hour. So that's really tough too, because we want to take care of all the swelling in that residual limb. So we lay them in supine, elevate their foot because gravity is going to help the swelling, but that's going to promote hip flexion contraction. Guess what? There's other ways we can work on swelling. It's not worth it. That's that clinical judgment. Like, where do I place the let's do this, let's not do that? Nope. Contracture is the big problem here. We'll fix your swelling, but contractures we have to avoid, and avoid abduction of the hip. Transtibial, now we're below the knee. So BKA is the abbreviation for below the knee amputation. Avoid hip and knee flexion. So now we still have the hip flexion contracture concerns, but now we also have the knee flexion contracture concerns. Now, we talked about lever arms a lot in test and measures. If you're going to stretch somebody's hamstrings, you need a long lever arm to do that. If they have a below the knee amputation, do you have a long lever arm to stretch someone's hamstrings? No. So you made your job infinitely harder if we have that contracture. So it is so hard for a below the knee amputation. If they have a knee flexion contracture, it is so hard to fix it because we just don't have the lever arm to generate the force to stretch it out after it happens. So it is crucial to prevent this from happening. Residual limb not be elevated for more than supine, more than a few minutes each hour. Avoid sitting no more than 40 minutes an hour. But if we are going to be sitting, that residual limb, the knee has to be straight. Find a way, prop it up, grab a footstool, like get the leg straight. If you're going to sit, get the leg straight. I can stretch out the hip okay. Like if we have a small contracture of the hip, I've got enough lever arm, I can still stretch out that hip. Knee, good luck. It is a real problem. Prone as much as possible. Other considerations: hemiplegia, neuromuscular weakness. That's what hemiplegia means. Avoid, if the upper extremities are involved, avoid prolonged shoulder adduction, internal rotation, elbow flexion, forearm pronation or supination, or hand squeezing. And if the lower extremity is involved, avoid prolonged hip and knee flexion, hip ER, ankle plantar flexion, that should say, not PT. I'm so got so much PT on the brain. Rheumatoid arthritis, avoid prolonged immobility of joints, especially if the joint is positioned in flexion. So these kind of people, we want as much movement as possible and not less. Gentle, active, and passive range of motion should be used for them. Burns have a particular concern with it, especially if they cross the joint. So as the skin heals of those burns, if we allow it to heal in a flex position as it crosses that joint, now that is going to, now the skin itself is going to be contracted, and boy, that's a nightmare to try to fix. So avoid prolonged positioning of the joints of all. We want to be moving those joints. If the burn does cross the joint, we're going to be moving those all of the time. Avoiding positions of comfort that don't place stress on the tissues. Frequent range of motion exercises. And prevent contractures. Orthopedic considerations: total knee arthroplasty, that's the knee replacement. Also TKR is the other abbreviation you'll see for that. Knee extension is the big thing we want to focus on. That's the number one thing we want to focus on. Our techs here, anybody ever see after a knee replacement that knee's not going straight? Nightmare to fix, right? I mean, it's, anybody ever try to walk with like 30 degrees knee flexion? On our next break, when we go get water, nobody's allowed to extend their legs all the way. Okay. Walk get your water and do that and tell me how it feels. Yeah. No, it's a big problem. So we've got to focus on that knee extension as much as possible. And then hip, avoid excessive hip adduction, rotation, flexion past 90. We've covered that a lot. Draping is pretty easy. Draping is using sheets and to protect patients' modesty, not exposing tissue that body parts that we don't want to expose, especially if in the hospital setting, we're thinking we're still in the hospital setting. What's the uniform of patients in the hospital setting? Johnnies. Yeah, Johnnies. Are they cover a lot of body or not? No, they don't cover a lot. They're big, bulky. It doesn't take much for them to twist around, and so draping is good to protect our patient's modesty. But draping we're going to be using all the time, and I know our techs probably do this with their outpatient jobs too. So frequently patients are going to need to remove clothing for our treatments. We need to access to the skin. We're going to be applying, substances that might soil clothing. So we like to protect the clothing as much as possible. So draping is a skill we're going to be using a little bit this semester. When we go into our modalities course next semester in PTA 2, that's when draping is going to be really important. But we'll show you some stuff now. Before removing any patient's clothing, even just moving a shoulder strap out of the way, communication is a must. It's so easy to get so busy, and I keep saying we are weird. We're weird in here. After you've taken kinesiology, you've palpated every single inch of your classmates, and every single inch of you has been palpated by your classmates. We are infinitely more comfortable with seeing and touching bodies than the general public is. So it's so easy for us to have a shoulder strap or a bra strap in our way and just to move it to get access to the tissue we want, right? And it's so easy to not even think that that's a problem because we're weird, right? But it's a huge problem for the patients, right? So if we're going to be moving clothing, we have to say, hey, can I do this? That little step of consent is an absolute must. Draping with clean linen, that's nice. That's a good step. All right. For our patients who are going to be using this a lot, any folds or wrinkles in the sheets that's a higher risk of pressure injuries. So eliminating that as much as possible. And then don't reuse with other patients. Draping procedure, I'll let you go with this on your own. I think there's a lot of this that just is intuitive, but look at it on your own. What I do want to show you, I'll show you this couple of techniques. So after we have our patient, actually, can I have you? Let's go sideline. And face your class that way. Yeah. All right. So there, we got it there. Got this sheet. So, our initial draping is just patient's going to be like this. I mean, patient comfort is something that we want our patients just to be warm. So we drape them just for that. Now, if I need to access tissue at his hip, I want to be able to expose that so I see what I need, but not exposed to the rest of the world. So I'm going to show you this with the hip, but we can use it for a whole bunch of different body parts should we need to. So for that kind of thing, I would use a 2-sheet method. There you go. Yeah, right there. So I've got a top sheet and a bottom sheet. Now I can create just a little window where I can now expose his skin to what I need to see without exposing his skin to the rest of the clinic. You guys that are techs, have you seen similar things like this draping in the clinic? Yeah, perfect. You want to go prone for me? Yeah, yeah, and private rooms. I mean, sometimes it's just better for a private room, but sometimes if I just need to work on the back, yeah, I can just tuck this in the belt line here, and then I get to expose the skin. I could even go way further south should I need to, just check the anatomy that you need to. So yeah, draping procedure to protect the patient's modesty is a must. So anyway, thank you. Appreciate that. You want to stay there? You take a little snooze or yeah. All right. So there's our review. Man, we learned a whole bunch. What I really think is important, not only pressure injuries, again, my decision tree for pressure injuries is it superficial or deep? Superficial, okay. Stage 1 or 2, is the skin broken or not? If it's deep, deeper structures or not. That's how I figure out the appropriate stage. For our patient position and pillows, one, just the checklist of where do the pillows go. That's your kind of checklist. But each position has its own risks of contractures that we can't fully eliminate. So I think the next thing you guys have to figure out is what would my next position be? Okay. And then something that, those special considerations for those conditions that we just talked about. Do I have any questions? All right, let's take another 10 minutes. When I come back, we're going to practice a bunch of stuff with some scenarios, and then we'll wrap it up after that, okay?